Welcome. I'm Jessica Farringer. I am the project director for Global Health Pearl, and I'm very excited to welcome you today to our first global webinar. And the topic is lead in drinking water in low and middle income countries. We're sharing preliminary findings from a systematic review. Let's see. Let's go to the next slide, please. So for closed captioning, you can select that if you wish to see live English captioning. At the bottom of your screen, you should see a CC live transcript button, and then you can choose from there which of the settings you would like to have. Next slide. So I'm just providing a short overview of Global Health Pearl, and then we'll be passing it on to our webinar facilitators and moderators. So Global Health Pearl facilitates the effective generation and use of high quality data and evidence to strengthen policies and program implementation to improve health and save lives in low and middle income countries. GH Pearl provides global technical leadership with a broad range of cutting edge activities in monitoring, evaluation, research, and learning, along with related knowledge management and knowledge translation to provide USAID supported countries with high quality, actionable evidence to assess program effectiveness, identify and overcome barriers to program implementation, and to guide decision making. To reach its goal, GH Pearl will achieve 4 intermediate results, or IRs, that you can see outlined here. The first is effective evidence generated. The idea here is to improve the quality, availability, and timeliness of evidence and data for learning and action. Then our second IR is strengthened capacity, strengthening local organizational capacity and systems to produce, analyze, visualize, interpret, report, disseminate, and use high quality data for decision making. And then our third IR is improved metrics and tools. The idea here is to design or improve, test, and apply robust metrics, methods, guidance, and tools for MERL. And then the last IR, which is critical in achieving all of the others, is increased knowledge use. So through knowledge management and knowledge translation, GH Pearl will conduct knowledge synthesis, translation, and management to inform decision making. Then with that overview, I will pass on the next slide to Jesse Shapiro, who's the Senior WASH Advisor with USAID. Over to you, Jesse.
Thank you so much, Jessica. Good morning, everyone, and welcome to the webinar. As Jessica said, my name is Jesse Shapiro. I'm the Environmental Health Team Lead and Senior WASH Advisor in the Bureau for Global Health at USAID, and I'm also the agency's Water and Lead POC. On behalf of USAID, UNC, UNICEF, and WHO and GH Pearl, I'd like to welcome you all to this important webinar this morning on lead in drinking water in low and middle income countries. I first want to sort of offer thanks to UNC, who has really provided the thought leadership and conducted the research and findings that will be shared with you today. USAID is very excited to contribute to accelerating the sharing of these findings. USAID investments in global research and learning in the WASH and WRM sectors is part of something we call our Action Research Initiative. This is a suite of efforts to support the generation of evidence and learning. More than just research, the initiative really seeks to maximize the use of evidence and learning and to improve the effectiveness and scale of policy and programs in the WASH and WRM sectors. We're really trying to avoid generating findings that just sit in a report on a shelf, but that are really relevant, timely, and trusted evidence that can directly inform policy and program decision makers so that it gets used. While lead in drinking water is on the global agenda through initiatives like the Global Initiative for Lead-Free Water, and it's also been a very high priority in places like the United States, our current political administration has really made lead mitigation and lead in water in particular a national priority. However, that would have never happened without the information to act on this issue. I'm sure many of us would agree that one of the barriers to action around the world continues to be insufficient data and understanding of the issue of lead in water. And when our current administration prioritized lead mitigation, I can say that at USAID, we really face the challenge of how do we contextualize the lead exposure from drinking water compared to some of the other high WASH priorities and key lead exposure priorities. And without enough information, it's really hard to know how or where to act or how to create joint efforts on the issue. Well, today I hope that we provide an initial contribution to address this gap and create some action. It is a really call to action for us all. Lead is in drinking water around the world at levels that are unsafe. While it may not be the largest or most immediate threat in every context, it is a significant and will be a priority once other threats are minimized. It's also complex to address, and we must begin to act now. As part of our efforts at USAID, in partnership with UNICEF, we recently launched something called the Global Partnership for a Lead-Free Future. This is a global public-private partnership dedicated to tackling lead exposure in LMICs. The partnership has committed to ending childhood lead poisoning by 2040, bringing together governments, public and private sector organizations to create a lead-free future for every child. Drinking water is very much a part of this partnership, and encourage you all to consider joining and making the pledge for global lead-free drinking water. So let's jump into the content of the webinar. Today, we're going to have 3 presentations followed by a short question and answer panel by the 3 speakers. So as the webinar is going, please feel free to add your questions into the Zoom question and answer feature, or you can hold them to the end. Our first presentation will be with Jorge Alvarez Sala, who will present on the health effects of lead in drinking water. Next, we'll hear from Michael Fisher from UNC, who will share the preliminary findings from the systematic review on lead in drinking water from low and middle income countries. And then we'll hear from Bruce Gordon at WHO, who will talk about what we should do next. So without further ado, let me introduce our first speaker, Jorge Alvarez Sala. He is the acting senior advisor for water and climate resilient WASH at UNICEF, based in New York. Over to you, Jorge.
Thank you very much, Jesse. Just a clarification, I'm WASH specialist, but still working in New York. If we move to the next slide, we are going to go through the health effects of lead in drinking water. Lead, as Jesse introduced, is a chemical of significant public concern, according to WHO. It's a chemical that affects nearly every system of the body, including kidneys, reproductive organs, and has particular adverse effects on cardiovascular systems and neurological development. Young children and pregnant women are particularly vulnerable to lead exposure, and lead is stored in the bones and can be released into the blood during pregnancy, for instance, and become a source of exposure to the fetus. There is no safe level of lead exposure. Next slide. WHO estimated in 2019 that nearly half of the 2 million lives are lost to chemical exposure is because of lead exposure. Therefore, is not only an important chemical, but is responsible for half of the deaths annually. It accounts to a significant amount of disability due to long-term effects on health, including 30% of the global burden of developmental intellectual disability of unknown origin. And we estimate that 800 million children, nearly 1 in 3 globally, are estimated to have blood lead levels above WHO standards as a threshold, and which recommends action to be taken to determine the sources of lead exposure and to reduce exposure. In some countries, this percentage is much higher. In some countries, we have found that 80–90% of children have blood lead levels above the WHO standard. While this figure shows elevated exposure, it is disproportionately, as you can see in the map, in lower and middle income countries. So it should be remembered, however, that lead is a global problem that affects also high-income countries, and that, again, there is no safe level of lead exposure. In the next slide, you will see the 10 chemicals of major public health concern according to WHO, and you can see that lead is one of them. But as I said, 50% of the deaths are attributed to lead poisoning. Next slide, please. Here you can see the different sources of lead. Each case, each country, each context is different. In some countries, the main source of lead exposure could be paint, or in some countries, it has been found that turmeric is the main cause of lead poisoning because sometimes turmeric is mixed with lead compounds to keep the color, or water, as you know, in some cases. So reducing any exposure of lead supports the health protection efforts. Even if lead in some cases might be a minor contributor to this lead poisoning, it is still good to consider lead mitigation initiatives. Lead in drinking water should be considered as part of a broader effort to improve the safety of drinking water and public health, and should be considered also as part of a broader effort to reduce lead exposure, considering all these lead sources. Lead in water is a contributor to lead poisoning, and it is difficult to establish this contribution on a global scale. What we know now is that lead in water is maybe more widely known or more widely present than we previously knew. In the next slide, we will see some examples of articles that have been recently published on mainstream media about lead in water. This is, as you can imagine, a very sensitive issue. Usually when we speak about water quality, users start to panic. So we don't want people to panic. We don't want to create unnecessary alarm among the population. We want decision makers and utilities to panic, to act, but rationally. And we don't want users to just shift to other sources of water, such as bottling water in developed countries or in low and middle income countries to other unsafer sources. So we need to manage this in a rational and scientific way to make sure that we balance this alarm and action. In the next slide, we will see how big is the problem in drinking water. What we know, well, lead is an issue in both high and low income countries in terms of drinking water, and in both rural and urban settings. A study by UNC, the University of North Carolina, identified a significant proportion of scrap samples from components of AfriDev and India Mark II pumps with a very high percentage of footballs and tap spouts that contain lead concentrations well above the recommended, some of the recommended international standards. Roughly speaking, a little bit less than 10% of water points in those investigated areas were delivering water above the WHO standards for lead. So the extent of this issue seems to be much bigger than previously known. However, it is not completely known. There are main elements that contribute to elevated lead in drinking water, but we don't know exactly which materials in which cases, and we don't have all the answers to the questions. Next slide. This is my last slide. Going back to the relevance of lead in drinking water. Lead comes from lead pipes, that's obvious, but not only. It also can come from brass components, fixtures, PVC pipes, galvanized iron pipes, equipment, in particular materials and equipment that do not meet national or international standards. So I would like to mention here the importance of making sure that the quality of the materials and equipment that is being installed meets the international standards. The fact that there are standards doesn't immediately ensure that manufacturers follow those standards, in particular in low and middle income countries. Later on, Bruce will further develop this, but I wanted to make a special mention here. because most lead comes from leaching from those materials, and that has implications in terms of remedial actions, but also in terms of monitoring, requiring specific testing protocols. But allow me to stop here and maybe move back to Jesse.
Jorge, thank you so much. One thing I heard you say that I think bears repeating is no level of lead is safe in drinking water, right? And these developmental burdens, especially on children, is very high. So now we'll shift over to Mike Fisher, who is an assistant professor at the University of North Carolina at Chapel Hill, and he has spent the last several years leading a global review of lead in drinking water, and talk about what they found in their systematic review. Over to you, Mike.
All right. Thanks very much, Jesse. And thank you, Jessica, for that wonderful introduction and background. And thanks so much, Jorge, for painting the picture of the public health importance of global lead pollution, lead in drinking water, and taking a look at what's going on with lead in drinking water in low and middle income country settings. And as Jesse mentioned, and thanks very much to USAID for helping accelerate this, we've been working with numerous collaborators on a systematic review to try and understand what's going on with occurrence of lead in drinking water in low and middle income country settings worldwide. And just a brief bit of background, I work with the Water Institute at UNC, and our focus really is on the intersection of science, policy, and practice, and particularly identifying opportunities where more, better, and more usable evidence can be relevant to policy and practice. And the approach includes identifying problems, developing usable solutions, working with partners to demonstrate that these can work in real-world contexts, and participating with global partnerships to scale up the action. And here are just a few of the folks who collaborated in leading this work. As Jorge has already done a wonderful job of explaining, we have good evidence on the serious and potentially irreversible toxic effects of lead exposure throughout the life course, and the particularly challenging and irreversible neurodevelopmental and cognitive impairments associated with lead exposure in early childhood and in fetal development. We also have great evidence and guidance, which Bruce will talk more about, from WHO and others, telling us that lead primarily in drinking water arises from corrosion of unsuitable drinking water system components that contain higher levels of lead than international standards dictate, and that this is entirely preventable. And finally, we know from US and high-income country evidence over the last couple of decades that after we tackle lead in gasoline, lead in paint, we still have a substantive burden of child blood lead levels in the US over the last couple of decades associated with lead in drinking water. And in recent decades, evidence suggests that this can account for up to 20% of child blood lead, and even more in infants who are fed on formula. And so this suggests that if we eliminate lead in paint and lead in gasoline, we still don't get all the way to a lead-free future for children without also tackling lead in drinking water. And so we have evidence that Jorge has done a wonderful job summarizing, that lead is harmful, that it's important to public health, and that it's preventable. But the big question that hasn't been adequately maybe addressed, synthesized, and communicated is the question of how prevalent is lead in drinking water across low and middle income country settings. And so that's what this systematic review set out to address. And so just a brief overview of methods. Systematic review is often considered the gold standard for gathering and synthesizing all the published evidence that's out there. And this is an approach that's widely used by World Health Organization, US agencies such as EPA, CDC, NIH, and others. And there's a well-documented process for searching all of the published evidence, screening, gathering, extracting the evidence in a reproducible way, so that it can be used and so that we can have reasonable confidence that the findings are representative of the evidence that's out there. And so the PRISMA statement describes a widely recognized and used approach for doing this, and that's the approach that we followed for this work. Our initial search on peer-reviewed studies published in the last 50 years or so that presented primary data on lead and a number of other toxic metals in drinking water actually returned a tremendous number of results, more than 25,000 potentially relevant results. And that was too many for humans to screen. So we used some approaches to try and narrow that down. I'll just mention that our inclusion criteria included full text articles available in English. And while that might seem to be very narrow for a global systematic review, it's actually the case that over recent decades, the vast majority of scientific articles published in technical journals worldwide are published in English. So even though we don't capture all of the evidence that way, we actually get a very large proportion of the available peer-reviewed evidence that's available full text in English. But as I mentioned, our initial search returned more than 25,000 results. And so we worked with some wonderful librarians at UNC's Health Sciences Library to train a machine learning tool that they've previously published to help identify and eliminate non-relevant documents so that we could prioritize the results that are most likely to be relevant. And so that reduced our 25,000 search results to less than half, to about 13,000. And then humans were able to eliminate those that were irrelevant at the title and abstract level so that we could then work with a large team who will acknowledge at the end of this to read over 2,000 relevant studies and extract the usable data and put them in a format where we could have the best opportunity to try and compare them apples to apples to tell a story about what's going on with lead and toxic metal occurrence in drinking water worldwide. And we did that, again, according to a widely accepted standardized systematic review procedure. One of the things that the procedure requires is to look at all of those studies to say something about the risk of bias within individual studies and across all the studies. And so in order to do that, we developed a method quality score where we assigned points for all the elements of the sample collection and analysis methods that are required to quantify lead and toxic metals at levels of concern in drinking water, so with part per billion sensitivity. And when all of the expected items were present and adequately reported and described in the publication, then we assign higher scores. And when they're either inadequate or, much more often is the case, they're just simply not discussed in the article, then we assign lower scores. And what we see in the table on the left is that individual articles tended to have low to medium method quality scores. But when we look at all of the studies together, what we know from the literature is that we typically expect concentrations of lead and toxic metals in drinking water to follow a log normal distribution. And what we actually see when we look at data across all of the studies, when we look at the central tendency for each study across thousands of observations, we actually see that they fit quite well to a log normal distribution altogether around the concentrations of concern. So that WHO guideline value, 10 parts per billion, up to 3 orders of magnitude above and below, we actually have a very good fit to a log normal distribution. And so what that suggests is that while our individual study quality varies and individual studies may be quite limited, collectively, the data look roughly like we might expect them to. And so we don't see massive evidence of bias collectively when we look at all of these studies together. And so that's helpful for saying we can learn something from all of the evidence that's out there, despite the fact that individually, study to study, there are many things that we might like to be different or reported more adequately. So when we do look at all these data together, we see, just looking at lead alone, about 1,450 or so data sets from which we can extract usable data. and more than 85,000 usable observations. And so it's worth mentioning that an individual study will have at least one data set if it reports on lead, but if they report on a few boreholes over in one district and then some pipe sources over in a different district, we might treat those as two separate data sets just because they're more similar than they are different. So we got over 1,400 usable data sets, over 85,000 usable observations. And when we look at the global distribution, there are data across WHO, across SDG regions, but we don't have peer-reviewed evidence from every country that's already included, and we have an uneven distribution. So 6 countries comprise more than 60% of the data. Fewer than 7% of our usable data sets were from Latin America and the Caribbean region. And each of these data sets here, very few of them are nationally representative data. Again, much more might be 50 or 100 samples from one district or one city or even one part of a community, rather than large nationally representative data sets. And finally, while again, we have a large enough data set that we can say things, even when we slice the data up by region and by source, it's worth noting that fewer than 10% of our usable data sets reported on pipe sources. So what's the big takeaway? The big takeaway is that lead occurs at levels of public health concern across low and middle income country settings. When we look overall at 1,467 usable data sets, 35% of observations report levels exceeding 10 parts per billion. So exceeding the WHO guidelines for lead in drinking water. Now, it's worth noting that of those 1,467 data sets, some of them went looking for pollution where they expected to find it. So some of these are from landfills, some of these are from mining areas, industrial sites, but a subset of 639 non-targeted studies. So these are studies that didn't go looking for a known and suspected source of pollution, but just looked at drinking water without reporting a nearby localized suspected source of pollution. Those non-targeted studies, 34% of usable observations also were reported to be in excess of that 10 part per billion WHO guidelines. And now, a lot of studies use different methods. Some are more sensitive, some are less. But of those non-targeted studies that use the most sensitive analytical methods, so that's inductively coupled plasma and mass spectrometry, we looked at 20 to 25% of those samples exceeded 10 parts per billion. And we'll talk more about this later. But it's worth noting that data from China were qualitatively different than data from other countries in the study. And so when we look at all of the non-targeted best method studies, not including data from China, we see about 25% of reported results exceeding 10 parts per billion. And so for all intents and purposes, these are really telling the same story. They're telling us, does lead occur at levels of concern in drinking water in LMIC countries? Yes, it does. And any way we slice the data, it still occurs at levels of concern. Moreover, when we slice the data by water supply technology type, looking at boreholes, pipe supplies, all wells together, we don't see big statistically significant differences between these different technologies. So yes, it occurs at levels of concern across different water supply technologies and across different SDG regions. So we do see some differences across SDG regions, but there's no region that is exempt from this issue. We see lower levels of exceedances for Latin America and the Caribbean, and that is a significant difference in a meta-regression. We also see lower levels in Eastern and Southeast Asia. However, a lot of that effect is attributable to data from China. And so when we look at the region X China, that significant difference is no longer significant. That makes sense. So again, we see across source types, across regions. When we slice it by rural and urban context, we also see lead occurrence across urban, peri-urban, rural, and mixed settings. Slightly lower, maybe, in some of the mixed setting studies, but again, we don't see just a rural story, just an urban story. We don't see just a pipe story or just a borehole story. We see across settings, contexts, and even across decades. So when we look at the decade in which the study is published, we don't see very strong secular trends or effects that, oh, well, it's just the older studies or just the newer studies. We see across decades, again, a substantive proportion of observations exceeding that 10 part per billion WHO guideline value. Finally, as I mentioned, when we look at analytical methods, we do see that studies using the most sensitive analytical method, ICP-MS, are associated with fewer observations exceeding that 10 part per billion guideline value. Now, that doesn't necessarily tell us anything about causality. It could be that more sensitive methods give us better results and tell us about less occurrence. It could also be that settings where more sensitive methods are used may also correlate with higher income or other factors that are associated with lower levels of occurrence. So we're not saying anything causally, but we do see that the more sensitive methods report less lead. But even in those non-targeted studies with the most sensitive methods, we do see 20-25% of observations being reported as exceeding that 10 part per billion guideline value. So just to summarize the findings, the big takeaway, does lead occur at levels of concern in drinking water in low and middle income countries? Yeah, it does. And we see that worldwide across different source types, across urban and rural and peri-urban contexts, and across different decades. We also see that this is across regions. No SDG region is exempt from this. We do see that Latin America and the Caribbean and potentially East and Southeast Asia may be lower, but we still see lead occurring at levels of concern across all regions. Similarly, we see it across all study methods, but those studies using the most sensitive methods may be lower. And finally, it's worth noting that a lot of the data from East and Southeast Asia and a lot of the ICP-MS data are out of China. And we see that data from China are qualitatively different and report lower levels of lead. We don't know why that is, but it's worth mentioning that some of the regional and or method effects may be due to those differences. So those are the big findings and takeaways. Next steps for this, it would be really useful to take all of the evidence and find a way to make it more usable. So hopefully this webinar is valuable. Hopefully the report and publication that come out of this will be useful. But in the future, if there's opportunities to turn this into something that is more practitioner-oriented, such as a living systematic review platform that helps policymakers and practitioners answer questions, that might be one potential next step that could be relevant in the future. And of course, all these data are already publicly available and will be made available in the synthesized form. In addition, we looked at peer-reviewed studies only in English, but there may be lots of high-quality data out there that haven't been published in peer-reviewed journals. That's what we mean when we talk about the gray literature. And so in the future, if there's opportunities to incorporate gray literature, data sets from government, civil society, and others that are high quality, that may really increase our ability to answer questions about lead occurrence in drinking water. And finally, we had very few nationally representative data sets. And so as governments, agencies, such as UNICEF with MICs and others, are increasingly doing national and subnationally representative monitoring and surveillance, as those data become available, integrating those may be extremely valuable in painting a better and clearer picture about what's going on with lead in LMIC drinking water broadly and at the national and subnational level. The big takeaway, though, is that while there's a lot we'd like to do and a lot we'd like to learn, we don't necessarily need more evidence to take certain important primary prevention actions. We already are able to synthesize the available evidence, and it's reasonable to say that that evidence is sufficient to undertake no regrets prevention actions now. And what I mean by that is whether lead occurs above 10 parts per billion in 20% or 30% or 10% of LMIC drinking water, or even more or less, we'd still want to undertake primary prevention to do what we can to prevent that, especially because we know from WHO and others, and we'll talk more about that later, that lead in drinking water is highly preventable if we're able to construct water systems with lead-free materials. So it's worth saying that the point estimates, is it 25%, is it 34%? Those will change as we get more and better evidence, but the recommendations will not. If our point estimate of the proportion of LMIC drinking water exceeding WHO guidelines, if that were to double or triple or be reduced by half or even 1/3, we'd still want to undertake primary prevention to protect populations and children from lead occurrence at those levels. And so what we're able to say is that while it's very likely the point estimates will change, it's unlikely that they would change so drastically that we'd make a different decision. And that's why we can say that the available evidence right now is sufficient to undertake no regrets prevention action. So that's the big takeaway. Separately, however, there are important evidence gaps that could be addressed, and we could benefit from addressing those. It would be great to know more about national and subnational occurrence distributions, to look at supply chain and vulnerability mapping to understand the sources of lead-containing materials in water systems and what we can do about that, cost and impact of different evidence-based prevention and remediation solutions, relative contributions of drinking water and other sources of lead exposure to blood levels and disease. And it's worth noting those are a moving target, right? So we see high contributions from paint as we make progress on paint, while those relative contributions are going to decrease. And we already know from high-income country evidence that the relative contributions of water can't be ignored. So we don't do anything different around primary prevention, but it's still really useful to know because countries and implementers have finite resources, and this evidence can help them make better decisions at granular levels. Lots of opportunities to address these gaps to help inform corrective action. Again, there's a lot we can do around primary prevention for new water systems, constructing them with lead-free parts. But when it comes to potentially more involved, costly, logistically involved remedial actions, well, more evidence can help inform fine-tuning those corrective actions. However, like we said, there's really very low likelihood that any additional evidence we're going to get is going to change the fundamental recommendations on primary prevention, which is that to the extent that governments and implementers are able to prevent new water systems from being constructed with lead-free parts, that's very likely to reduce the occurrence of lead in drinking water. And it's unlikely that any further evidence we get would cause us to make a different recommendation about that, if that makes sense. One opportunity to take action on that, and several governments and other participants in this webinar have already done that, is the Global Lead-Free Water Initiative. And so that is a global initiative to eliminate lead in new drinking water systems from 2030 onward, and to eliminate lead in drinking water entirely by 2040. And so many governments, implementers, and others have already signed on to that initiative. And to those of you to whom this is new, I would strongly encourage you to visit globalleadfreewater.org to learn more about it. And if there's anything that we can do to answer questions or assist, please let us know. And finally, WHO has put out wonderful technical guidance on lead in drinking water, which we'll hear more about from our next presenter shortly. And I'd like to thank many individuals who've made this possible, all the collaborators listed below, many partners who supported this work, including generous funding by USAID through GH-Pro. So thanks very much for that. And over to Jesse and Bruce.
Thanks so much, Mike. Very clear and compelling case that lead in drinking water is prevalent, and we need something to do. And you can already see some of the questions in the chat box are saying, what can be done? So perfectly timed. We have a presentation. I would like to hand over now to Bruce Gordon, who's the unit head for water sanitation, hygiene and health at the World Health Organization and vice chair of UN Water, to tell us what should be done. Over to you, Bruce.
Okay, well, thanks so much, Jesse. And just let me preface this by saying what a pleasure it is to go after Jorge and Mike, which makes my job very easy because they've covered quite a bit of it. And also, obviously, a big thanks to you, Jesse, USAID, and the US government for bringing this to the world's attention and adding an extra push. So I think we've heard that, just let me say that there's been a lot of there's a lot of challenges with lead. It's a very interesting contaminant. Um, from establishing a guideline value, interpreting that guideline value, developing an approach to sampling, interpreting those results, the complexities and options around mitigation, and really the sort of neglected piece around communication, which is quite important. So I'll focus more on the technical of what can be done and maybe go to the next slide, please. But I did want to mention that the prevention piece, and this is, I think, Jesse, you may have alluded to some of this, is really important. And I just wanted to say that I think right now, as we speak, countries are negotiating a possible World Health Assembly resolution to reduce and eliminate lead, including in drinking water. So that may be expected. And I know I've looked at some of the drafts, and drinking water is nice and prominent. The G20 has a call to action. We just did a webinar. My colleague, Jennifer de France, who is leading the drinking water quality program here at WHO, and she's on maternity break, actually. So I'm filling in, but she did a webinar a couple of weeks ago. We had a water action agenda, which I think Ryan is mentioning in the chat, the Global Lead-Free Pledge. A top 10 chemical of concern. And of course, all this is given a big boost with this partnership for a lead-free future. So that is tremendously important. But if we go to the next slide, and I can't not speak about the guideline value just for a moment as WHO. I won't spend a lot of time, but we've heard, of course, this issue around there's no safe level. And I think for all intents and purposes, there is no safe level. But let me just be precise and say that no safe level has yet been identified. And I say that just because, public concern in the sense that when you get lower and lower in terms of concentration, it's probably very close to safe. So that hasn't been identified yet, but it's not to say that, if you have very small levels, the population is being poisoned. But of course, the 10 microgram per liter, or that as Mike was saying, part per billion, as some of you see, is a management level. And that should be a country's first priority. So, get to that level. And then once you're there and have resources, try to do more to identify other exposures. I think I'll stop, just go on to the next slide because we're strapped for a little bit of time. So what I really want to zoom in here is this technical brief. And the reason that we did a technical brief is because of real life situations where government representatives dealing with public health or drinking water were faced with exceedances in their countries and worried about what to do. So there's a little bit of there's a little bit of anxiety. And the takeaway, I think, from all of us today is that there can and should be things that can be done, even at low cost. But this kind of anxiety does lead to a bit of paralysis because no one wants this news out in the public. And so, again, communication is important because there's things that can be done, and communication is one of them. So we did a kind of, next slide, a step-by-step kind of approach to, so you can, perfect. You can see there's a flow chart on the right-hand side of this slide. And is really trying to lead stakeholders through a stepwise and simple approach to dealing with higher concentrations of lead. And again, it's really trying to tackle some of this complexity. So when we talk about sampling, and I think Mike mentioned some of this, it's highly variable. He mentioned just variations, using different tests, but within the same household tap. Or even hand pump, you may get different concentrations at different times of day with different, kind of water chemistries with different stagnation times. And so, you can sample in such a way as to probably make things look good, or you can sample to make things, kind of take more of a worst case scenario. But the point of the brief was that your first real effort is to screen. So to try to broadly understand where exposure is happening. And And then once you've done that, it's really to understand that exposure. So in other words, yeah, there's a drinking water guideline value, but it's not so much like a country or city or even a household meets or doesn't meet that. It's what is the exposure to an individual? So really trying to replicate, what an individual is drinking and how they take their water to understand what type of lead exposure is happening. So there's ways of sampling as you get more and more sophisticated to quite to really understand how much lead is getting absorbed through drinking water. When we get into, I think there was some mention of the sources of lead. Of course, in many developed countries and developing countries, it's in household plumbing. But generally, materials in contact with drinking water is an important source of lead. And I'll talk more about that in terms of mitigation. But certainly, there are natural lead sources of lead as well, and there's industrial pollution that can pollute water and get into your water. So there's a bit of complexity to the sources. And then finally, on the corrective actions, again, there's stuff that can be done by a central water supplier, so it doesn't involve going from house to house to house, which is some things like adjusting the pH or the alkalinity of the water, introducing corrosion inhibitors. Of course, at the household level, there's simple things like flushing. You could potentially introduce household water treatment. That could be expensive for some households, and then ultimately get to replacement of lead pipes and fittings. But I think what the message, from the others also was that when we start looking at non-pipe supplies like hand pumps, it's not a matter of replacing them all and kind of going bankrupt with your water supply. It's a matter of like when you're ordering and procuring new hand pumps or replacements to make sure that you have a supply chain that's using certified material. So that's something that can happen right away, and we would recommend. You could say you're doing something, it's going to benefit the population in the future. So next slide. So there's a role for many stakeholders. In fact, there's a required, I guess, role for us to make a difference together. And it goes all the way from plumbers to regulatory agencies. But I won't read through all of these. But as I mentioned, I would say virtually every regulatory agency in the world would include lead in their standards. But also, very importantly, they need to have monitoring methods or protocols or approaches associated with that. And there's a role for the regulators to ensure that plumbers are certified and that they have a plan to inform users and other stakeholders. I mentioned the certification of materials and the training of plumbers, but there's a huge role for them. The water suppliers themselves, they can take many different actions to immediately reduce lead or over the long term progressively replace lead materials over time, and if resources allow. And I mentioned the hand pump story. And then, of course, a lot of this responsibility, frankly, in many countries is on the householders themselves, because the water supplier, they may, the responsibility may end at the property line. So there's a responsibility that is actually borne sometimes by households to take care of things themselves and to make sure they're flushing or installing filters or are making sure the plumbers they work with are trained. So yeah, I hope that is kind of inspiring in the sense that there's lots that can be done, and some of it can be done with modest resources. Again, a sampling strategy to understand the exposure a little bit better can be done, sort of in a modest way where you're just trying to focus where you feel like the problem is affecting the most vulnerable first. Next slide. So some takeaways, and these have been said before, but this is a health issue. And not dealing with it is a reputational risk because this information will eventually come out. But please, do not expect things, inspect. So if there are issues around elevated lead levels or compliance issues, further investigation is warranted. So everyone needs to take a deep breath and try to, better understand the situation, better understand the evidence, but at the same time, begin to take action and have a communication plan where there's numerous stakeholders involved, good communication between the water supplier and the regulator, and ultimately a plan to communicate with consumers in a credible, calm and clear way. So I think the next slide is my last one, Jesse. It is. Well, just to thank you and thank everyone. Over.
Thank you so much, Bruce. All right, now we're going to shift to Q&A. Maybe if the panelists can come back on. Thanks so much, Bruce, for the presentation. A couple things really struck me about what you said. First, that we shouldn't jump to conclusions that either this isn't a problem and we need to inspect, and we should also not jump to the conclusion that we just need to replace all the infrastructure, right? There's a more thoughtful strategy to trying to address this and reduce exposure over time. But also, it's not just about infrastructure, it's about communication. That's such an important piece, and that it will take all of us, multi-stakeholder. Cannot be solved by just one government or one actor. All right, so from there, I think we got some questions in the box. I'd like to ask the panel about what do you see, beyond the general guidance Bruce provided, what do you see as some low-hanging fruit or high priorities, tangible actions that some of those on the call and other stakeholders can take to start to address these issues? And just jump right in, I think, if you have a question, or maybe I'll call on Bruce to answer first. Put you on the spot.
Well, yeah, I think that's a great question, right? And it's the low-hanging fruit piece. And that's why one of the things that we kind of started when I mentioned this flow chart, we started, the flow chart with just this real trying to confirm findings, right? Because, there may be aberrant findings. They may not necessarily be representative of exposure. So, it's because lead is exposure over time, right? And the health impacts, I think that Jorge mentioned, they're not coming about from drinking a glass of water. They're coming about from drinking a glass of water over years at a higher concentration of lead, or combined with other exposures, right? It may not come from drinking water, but it's not something. So that's why I think it's the public communication piece, Jesse, is so important, because I feel like, whether it's lead or other, kind of emerging contaminants, people don't understand, exposure and dose, in the sense that they just see something as sort of like toxic or not, poisonous or not. And, this has to be, so the danger of that is then authorities that are dealing with it are just like, oh, well, if it's black or white, then we need to potentially really get nervous and not communicate it and not do something about it. And I don't know if this is the right word, but I feel like people should get a little bit more relaxed about it, in the sense that, yeah, this is a problem. Well, Mike, you said it, but it's affecting countries, rich and poor, all over the world. We've had countries and they come to us and they're very nervous. And we're like, okay, well, this is start with a screening, sampling, try to understand your problem, and then start thinking about remedial action. So I think there's lots that can be done, and better understanding the problem is probably a really good first step in a kind of calm way. So maybe I'll stop there.
Yeah. I'd like to really echo what Bruce is saying. And, first of all, I also really want to shout out some colleagues who've, done tremendous work on this. Dr. Zakaria Seydu and other colleagues at University of Development Studies in Ghana and University of Ghana, Legon, have really done the work of hundreds of people to make this possible. And one of the things that we see, again, like Bruce said, is widespread occurrence and really preventable occurrence. And so, one of my colleagues on this call, Solomon Manila with World Vision, has worked with us doing testing of water system components across Ghana. And we see lots of water systems that have components exceeding that 0.25% by weight lead international standard. And so that's one thing where, if countries and implementers don't currently have a specification that says lead-free parts could be used, that's where, they have clear authority to potentially take that action. And that combined with third-party verification. So if, every shipment of parts that comes through, if 1 or 2 or 3 is analyzed either, at the point of, port it's being shipped from or the port it's arriving at, to verify that those really do meet that less than 0.25% lead, that's a really good start. And that's something that falls under that category of no regrets prevention. So countries are sovereign. No one can tell them what to do. But to the extent that a country wants to take action or an implementer wants to take action, they have the right to say, hey, don't ship us anything for water systems if it's more than 0.25% lead. And by the way, we're going to get a third party to check. And the other thing that we see with implementing partners is a lot of the lead in water systems in Ghana, where Solomon and others have been working, a lot of that is in brass taps for pipe systems, brass valves and fittings for hand pumps. A lot of times 2-3% brass lead by weight is added to brass to make it easier to machine. And switching to a lead-free substitute like stainless steel is one thing that some partners are doing to dramatically reduce lead leaching. And generally, the cost difference is very small, especially compared to the part of the system. So that's not to say that if you've got a lead-free alternative that's working for you, that's great, right? It's not to say one material is better than another. But if you want a quick, low-hanging fruit, one thing that one partner did, World Vision, is they have eliminated brass taps in their drinking water system globally because it's easy to very quickly just check and visually verify, okay, yep, it's stainless steel, without having to subject it to complicated analysis. So long-winded, but those are a few low-hanging fruit things that countries like Ghana and others are working on, and that implementers like World Vision and others have undertaken that they have control over. Sorry, Jesse, I think you're muted.
You are correct. Thanks, Mike. Right. So quick things we can do is test, right? Verify where there is an issue and seek out like sort of the likely suspects, brass is a likely suspect. So try to seek out where those are and maybe replace those. And through policy, as you were saying too, around it's no regrets to institute a policy to remove lead from the supply chain. All right. There's another question about what is the relative importance of lead in drinking water versus spices, or maybe other exposure routes, and what is the potential effect size we will reach by taking action? Maybe I'll point to you, Mike, to kick us off on that, or Jorge. Yeah.
I'll give us a very quick response and go to others, which is, I think it's going to vary country by country. The evidence suggests that lead in water is too big to ignore. Where lead in spices is an issue, that's too big to ignore. But the analogy I say is, okay, well, setting by setting, what's the relative importance of seat belts versus airbags versus anti-lock brakes versus better traffic signage and laws? As long as all of them are too big to ignore and there's no regrets options around seatbelts, we don't change anything under management. However, the evidence about the relative contribution at any given location and point in time, it's useful. We don't make any different decisions around primary prevention, but as we get more and better evidence, we'll learn more about how those relative contributions vary, and they're going to be moving targets. As we make progress on one, others will become proportionally more important. But the high-income country evidence says that in the US in 2024, lead in water is too big to ignore, and so that's likely to be true globally.
Great, thanks. All right, so unfortunately, our Q&A time here has been short. We've actually reached the end of the hour, and we're going to have to wrap up the webinar now. We will commit to producing a FAQ based on this discussion and others, and we will put that out with some of the materials that will be shared after the webinar, which include the recording and any of the documents that were linked in the chat during this discussion today. And so with that, I would like to close up the webinar. I really want to send my appreciation to everyone for participating, and especially our organizer, G.H. Pearl, and our panelists and speakers from UNC, WHO, UNICEF, and USAID. We really appreciate you all this morning. So thank you so much for joining, and look forward to engaging further with all of you on this topic. Take care.
Thank you very much, Jesse. Thank you, everyone.